All right, my fellow panelists, while we're waiting for everyone to get on, let's kind of get to know each other a little bit. So when someone chimes in, kind of like how we were to go, if we were to go to a meeting and we're waiting, we'd all be saying hello to each other. So we're not officially getting started, but we're officially going to start a conversation because that's the whole point today. So I think I see Dr. Kasraeian. I see Dr. Taha, who I call Mr. GQ, and then Dr. Tan, who's our fearless leader. So how you guys been today, man? Anything interesting happened this weekend?
Yes, I am a week away from a baby girl, so I'll be calling you for a lot of advice. I have 2 boys, so this will be a new undertaking.
You need a vasectomy, man. I know a good urologist. Oh, man. Hey, you know what's interesting? I actually saw a patient today that's complicated like the one you guys are going to present, and I actually referred him to medical oncology without trying too hard on my own. So I know it's not the point of this, but just kind of prepping for this stuff has really been real educational for me. So, Chen, where are you right now?
Teamwork makes the dream work.
Yeah, and the stream work, as they say in urology.
Yeah, I'm working at the clinic today, so it's just a nice view, but I'm working.
So it's a green screen. Okay, we get it. It's all good.
Yeah, it's collaborative.
Yeah. And Taha, where are you? You're in South Florida, right?
Yeah, out of Delray Beach.
Oh, nice. So how do you even work? It's like you must have like a beach right outside your window there.
I'm like Dr. Tan. I'm stuck inside often, so the background's there for everyone to enjoy, but myself.
Well, that's kind of comes with our specialties, right? Like it's a life.
But we got weekends, which is good.
It's a life of self-sacrifice, man. So that's what it comes down to. So I think we're going to wait a few more minutes. I know we were going to start at 5:35, so we've got 3 minutes. And if anyone new has joined us, please go ahead and drop your name or who you are or where you're from in the comment section. We're going to be using that comment section a lot. I actually have a message I wrote for you guys as a moderator. Thanks for joining us. This is meant to be open and didactic. Please feel free to ask questions at any time during this conversation. Yes, we have a set agenda, but our main agenda today is to get everyone talking that's in the room. Say, Wayne, how are you, man? Thanks for joining us today. Sue,
hey, Wayne,
nice.
How are you doing? Welcome.
Hi, Sue. Good to see you as well. So Dr. Tan, while we're getting everyone's hello here, we got Patient Navigator from Tampa. We got Dr. Punnen in the house. What's up, bro? Welcome. We can officially get started now. So listen, I asked whoever the attendees are to go ahead and drop their name and what they're doing today and where they're from in the chat. So we got a whole bunch of good people here. We'll give them another 2 minutes to kind of all join us. And I think all of us panelists are on, which is awesome. So Dr. Tan, while we're waiting 2 more minutes, what's your favorite food?
Chinese food, which is obvious, but that's what I eat. Okay. Healthy food, try to, but sometimes not.
Does this mean I have to say Indian food? I don't know about.
No, you can eat anything you want.
I'm gonna go cheeseburger and fries.
I'm usually a cheese pizza kind of guy. Hey, Marty, ARP from Bond Clinic. Hey, how are you, Marty? Thanks for joining us. And Danny, Patient Navigator, I think I already gave you a kudos. Hello. And then we have Adam from Jupiter Medical Center joining us as well. So welcome. So that being said, we got a whole bunch of people joining us. I'm going to say it again. This is our first time doing this inaugural collaborative conversation. And it truly is supposed to be a conversation. If we had the ability to be in person, we would be in person, but we're going to try to do this as best we can through Zoom. But we want it to be just as didactic. So my name is Dr. Jamin Bromwat. I'm a urologist here out of Orlando. And we have some amazing panelists with us today that we're going to quickly, while we have one more minute before we officially start, just really say hello, where they are, and a quick tidbit about them that's not medical based. I'll start off with Dr. Tan, who's the Presidente of FLASCO this year.
Hi, I'm Winston, and I love to be in Jacksonville. I'm here in Jacksonville. I've been here for a couple of years and do mainly medical GU oncology. And besides that, enjoys the outdoor. And my favorite hobby right now is to kayak around the streams in Florida. So that's what I do on my free time.
And that's actually what you're doing right now, because we see you're on a boat somewhere in Jacksonville right now.
That's good. That's good. That's good.
All right, so we're going to want Dr. Kasraeian. I see you on here as well, a fellow urologist, but really quickly introduce yourself and your favorite thing to do beyond medicine.
Hi, I'm Ali Kasraeian. I'm a urologist in Jacksonville, Florida. I have a good fortune to work with my dad, which has been a very, very fun part of my career. I did a lab robotics fellowship in Paris for a year, which was great fun. And that really introduced me to the management of prostate cancer, which has become a great passion of mine. I love spending time with my family, my two kids. I've had kids later in life, so that's been a really, really fun thing to do. Hobby of mine, not many people knew. I played drums in a band all through school, and we toured and tried to get signed. Obviously, it was an epic failure, as I'm a urologist now, but looking to hopefully get back into music in some capacity so that my kids will let me play along with them in some way before I get too old.
Well, it's good, man. Well, hopefully you still have some ears left after you have your third kid now, and you'll have the screaming in both ears. So, all right. So we'll get Dr. Taha, who's from South Florida, kind of give us a hello here.
Madhi, medical oncology with Florida Cancer. What's that? I have two little girls, teen girl dad. So I'm gonna rub some of my good luck on Dr. Ali so that next week when his little girl comes is ready to go, making part of the club, the teen girl dad club.
I appreciate that. Thank you.
With my family. Yeah, it's a lot of fun. Can't beat it.
So that's awesome, Dr. Taha. Finally, Dr. Punnen, go ahead. Our final panelist expert here.
Thank you, guys. So my name is Sanoj Punnen. Grew up in Toronto, and then I did my fellowship at UCSF in San Francisco for 3 years. And then I've been in Miami now at the university for about 8. Like Ali, I also have 3 kids, and it takes up all my time. And as you can see, I've been getting more and more gray hair from that. Hobbies, playing basketball and surfing, which I thought I'd get to do more of in Miami, but hasn't panned out that way. But looking forward to tonight.
No, that's awesome. So thank you guys so much. And thank you. Listen, just some history for you guys. FLASCO and Florida Urologic Society have been kind of collaborating with Pfizer and other industry leaders on kind of getting us to communicate better. And my job is purely facilitation. We have experts here that see these patients and cases on a day-to-day basis. And as you can see here, we have a very packed agenda. Our goal is to kind of go over a case, start conversation, answer your questions, maybe even look into cases that you may be going through that may require some, second consultation or just a conversation with us. But our real goal is not to spread any major science. It really is communication. And how can we better communicate as urologists, medical oncologists, radiation oncologists, navigators, APPs, or industry? That's really what we're trying to do today. And you're going to see why this is more critical than ever through what we're going to start off with in our agenda is actually a conversation by Dr. Tan about the exact why we are coming together today as a group of, I would label us as forward-thinking healthcare professionals, because we truly are, after this conversation, hopefully going to start thinking more forward in how we can provide better care to our patients. So I'm going to hand the podium over to Dr. Tan. Dr. Tan, why are we having this conversation today?
Thank you for giving the highlight that we need to communicate with each other as a team. And additionally, we should collaborate. why did we thought about this project. We want to engage with you in a conversation today to learn from you, and we can understand a little better how we manage patients with castrate-sensitive metastatic prostate cancer. Nationally, you can see from this illustration to your left that we have been using basically the new hormone therapy in orange. Only about 30% of the time. And the standard of care today would be to use actually novel hormonal therapy in conjunction with LHRH agonist, antagonist, or surgical castration with these agents. And you will see here that over the past few years, 3 years or so, there's actually only about 15% to about 25% or so of patients in Florida getting standard of care treatment for their metastatic hormone-sensitive prostate cancer. We're not basically just talking about Tampa. We will have more conversations around the state in Florida, but you will notice here that in Tampa, it was 9% and at best 18%. So that's why we want to engage in the conversation to understand why is standard of care not being delivered to these patients. And we clearly have very solid data, which Dr. Taha will present to us later, that we can have an impact on their symptoms. And in addition to that, we can prolong lives by giving them doublets actually in this setting. Thank you, Dr. Brahmbatt.
So you mentioned, Dr. Tan, you mentioned that, there's obviously discrepancies. We have statistics here. So in the chat group, we asked a question, and go ahead if you're comfortable putting it on there. I was actually going to put 4 out of 10, but I just felt bad saying that. So if someone else put 4, I'll be honest, mine should be a 4 out of 10, is how comfortable I am dealing with these metastatic cases. And Julie, kudos to you, 9 out of 10. That's pretty awesome. So that being said, like, some of us are comfortable, some of us are not comfortable. And these statistics speak for themselves that we're doing a really, not the best job in managing these patients. And so that's why it's very important for us to kind of put a team together. And you guys are now officially part of this team to kind of figure out what is the workup, what is the management, and how can we give the best care to these patients. So with that being said, we have a case study for you guys, which we're going to kind of go over. And the conversation on this is kind of open for conversation. But when we start discussing this case study, if you think of some patient that you've had or some question that you have or a scenario that you may want to go over, please do not hesitate. Put in the chat and ask the question. We'd love to kind of engage you. And this is really just a case study of a case that's seen by some of our specialists, but it's more a catalyst for conversation. So that being said, I'm going to hand it over to Dr. Kasraeian, Dr. Tan, and the rest of the expert panelists. My disclosure for this is I am pretty good at moderation, but I'm not that good at anything we're about to discuss today. So I'm so glad and so fortunate that we have people like you to manage these patients and help us give the best care to our patients. So I'm gonna hand it over to you guys, and go ahead, guys.
So thank you, Jamin, for such a wonderful lead into our conversation, and the other panelists and our guests for this wonderful conversation, and Pfizer for helping bring us all together, and Dr. Tan for the wonderful idea of doing this in the first place. So this case is a real case, an interesting case of a second opinion of a young gentleman for the world of prostate cancer. So a 57-year-old gentleman, newly diagnosed with prostate cancer by an outside urologist to the facility. T1C Gleason 4+4=8 prostate cancer. His PSA was 16 at diagnosis. He did not go an MRI guided algorithm. So he did not have an MRI beforehand. When we discussed, is that something that he wanted to do or consider doing it, especially since he had the majority of his significant disease being unilateral. He did not want to undergo another biopsy, so we did not pursue that. So he's diagnosed with a standard 12-core biopsy. 2 out of the 12 cores were a 4 + 4 = 8, followed by 2, which were a 4 + 3 = 7 on the right side of the prostate, as you see there. And he had 1 core on the contralateral side that had the 3 + 3 = 6 cancer. His staging imaging that was completed, including a CT scan of the abdomen and pelvis, a bone scan, and a chest X-ray, were all negative for any evidence of metastasis or local advanced disease. And when we discuss all the management options for prostate cancer, including radiation therapy options, focal therapy options, which again, I don't think this would be the best case for, and surgical management, including minimally invasive robotic assisted technologies, which the majority of prostatectomies are done in that manner these days. He opted to undergo a robotic assisted laparoscopic prostatectomy and a bilateral pelvic lymphadenectomy, which he underwent in June of 21. His pathology upgraded and upstaged with a PT3B N0, again, negative lymph nodes, with a Gleason 5 + 4 = 9 disease. He had extra prostatic extension. Both seminal vesicles were involved. However, he had negative surgical margins. And what was the most interesting part of this for me was that his immediate postoperative PSA was 21. We rechecked it and it was 27. So Sanoj, Dr. Punnen, as a urologist and a urological oncologist, seeing this case, what would be some of your thoughts and some of the next steps in managing this patient?
Yeah, great case, Ali. So, I mean, obviously my concern is obviously the post-op PSA, not only just not going to 0 or having a good nadir there, but actually being higher than it was. And, you know, it's interesting with the guy that had more, you know, not a high volume of high-grade disease in the prostate, but it kind of tells you that you could be, you know, understaging things with conventional imaging. And we know that we have newer PET tracers that could be available in this space. But given where we are right now with his post-op PSA at 21 and then rising, you know, I would restage him, you know, kind of see what's going on. And then that was what I'd start with.
So if we can advance the slide, we actually did that. You know, we looked at the different imaging modalities available. We talked about the conventional CT scan with a bone scan. And then we talked about the Oxyman scan. At that time, actually, in our region, getting a PSMA PET scan would be quite challenging. And now we have 3 different centers that can do it. The challenge there, besides, you know, the hit or miss of whether insurances would cover it, is that it's flown into Jacksonville from Dallas on every Monday, and the 3 facilities that are doing it in the community jumble to get the cases, and we do them that way from that standpoint. So it's quite interesting, and we got patient teed up at the beginning when that was done. So this gentleman got an Oxyman scan, again, a wonderful scan, and has really helped us out in scenarios like this since its advent. And again, generally negative. He did have some bulky lymphadenopathy in the external iliac chain, and interestingly also had a periaortic lymph node of 1.2 centimeters. So, what would your thoughts be there, Dr. Punnen?
Yeah, so I mean, you know, so now you're basically restaging and classifying him as a recurrent castrate-sensitive metastatic patient. You know, so obviously, we know that local therapy alone is not going to be helpful in this patient. We're looking at more systemic lines of therapy. And so, you know, I think a lot of these patients we tend to handle as a multidisciplinary approach. We tend to have a tumor board where we'll see a lot of our metastatic patients because there's a role for all the different providers to really kind of come together here. So, you know, we would start him on systemic ADT. We probably would add abiraterone and prednisone in this particular gentleman. We'd be looking at the fact that he's, you know, he does have metastasis, but nothing in the bone, no viscera. So kind of, you know, lower volume, so to speak. So we would treat him with a doublet therapy. And I would actually get my radiation oncology colleagues involved as well, because there may be a role to do SBRT. You know, the periortics is here as well. There's lots of newer things coming down the pipeline with, you know, radio tracers and targeted agents like that too. But this is probably what we would have done.
So that's exactly Dr. Punnen, that's great. Ali, that's great. But does we have like 45 participants now. So welcome everyone that's joined us. Just out of curiosity, does any of the oncologists, radiation oncologists in the room feel like they should have never gone for a prostatectomy? Because if we're going to enhance communication, sometimes, did we do the right thing? Because they're kind of with us. So just out of curiosity, at least Dr. Taha and Dr. Taha, just to kind of throw a curveball here, let's just be real, right? We kind of question sometimes what other specialties do, but in this case, do you think there could have been a different outcome here?
Clearly in this patient, when the patient presented, the patient did not have evidence of metastatic disease. So doing a prostatectomy in this setting would still be a reasonable choice. But if the patient was given radiation plus hormone for 2 years, that's also a reasonable choice. I think hindsight is always very good, but in this setting, I would feel like prostatectomy, laparoscopically would be still a good option. We could never predict what could recur and what happens in the future.
From my standpoint, and Dr. Punnen, I would see what your thoughts are on this. For the younger men, especially with aggressive disease, they're and generally in advanced prostate cancer, there's two schools of thought. One is be extirpative. You'll remove the prostate with a prostatectomy. It's the only one that gives you a full idea of what the pathology is. So with margin status and lymph nodes, you can behave and act accordingly based on the pathology. And then, salvage and adjuvant therapies are a bit easier in terms of the functional recovery afterwards once their continence sets, more so than if we did radiation in this gentleman at 57 years old. What to do next if he recurred locally only with the seminal vesicles and all those involved. You wouldn't have known that. And that's a big deal in the younger gentleman, in my opinion.
And Dr. Kasraeian, Dr. Punnen, that's actually a question that there's two questions here in the chat. One is actually was more a comment, staging CT negative, but post-op CT with lymph nodes. Based on that, the question would be is like, was the imaging done at the same place? Because sometimes if it's one is done at a community center versus a tertiary care center, there can be some differences. And the second is, was there any somatic testing performed on this, I guess, tissue?
So I can comment a little bit to Dr. Kasraeian's question. And so I do think it's obviously, yes, it's a very peculiar case in the sense that he had progression in lymph nodes that were previously kind of negative there. But we do see weird things from time to time. And so I think it's a good case for discussion here. As far as the treatment for localized disease, basically, when you look at the biopsy, I think he's a candidate for either. You could look at him as a candidate for radiation and he would get 2 to 3 years of ADT, just given that he's high risk versus surgery. And I do think that there's many times where we look at these high risk patients and we kind of look at this as a surgery versus radiation. But the other thing I would be aware of is that almost every other solid tumor in the body we treat with multimodal therapy. And if you actually look at what his characteristics at RP was, he had some very high risk prostate cancer and significant disease. And these are the kind of guys that I actually think when they're young, like this patient was, they're going to be most served by surgery followed by radiation. And I would tell this gentleman, his biopsy didn't reflect his final path, but if you had some sense that he's that bad, I would almost tell those patients the likelihood that we're going to cure you with surgery alone is minimal. And, I don't look at it as hey, you're going to get radiation anyway, so just go with that, because there is a benefit to being able to get that adjuvant therapy in. So I do agree with surgery would being a good stop. The question about somatic testing, I think it's an excellent question. I think it is something that we should be doing in metastatic men. It's part of guidelines. So, whether it's going to be something you clinically act on at this stage with a castrate sensitive patient, we have great first line evidence there. But I'll leave this to Dr. Tan and the rest of the team.
This question often gets posed at our tumor board when we have a high risk Gleason patient that comes in, and whether they should proceed with definitive radiation or should they proceed with definitive surgical resection up front. And I always, if I can, favor the surgical resection up front, because that tissue is so valuable in regards to next generation sequencing and looking at mutations. And if they have negative scans like this patient did, and they're a young patient with a good ECOG performance status, I highly would recommend surgical resection, like in this case. It's unfortunate that he developed metastatic disease, but at the same sense, it leaves us with a good foundation of how to address the patient, how to look for genomic sequencing and next generation sequencing for mutations, whether they be HHR mutations or looking for a different outlier that we may be looking for. So I think the approach for this patient from a medical oncology perspective is 100% favorable towards surgical resection.
So with that, we're going to kind of move on with the case, but really quickly, just a really quick question here is, would no one favor biopsying the enlarged lymph node to evaluate for neuroendocrine conversion given the rapid change?
We actually talked to the patient about doing a biopsy, and he refused, as he did not want to undergo another procedure that soon after the.
So Dr. Kasraeian, you thought about that. Dr. Punnen, would you think about that biopsying? Would that even be a part of your conversation? Yes or no?
Probably not, because his PSA is going up. It's showing activity on a PET tracer scan. You know, that's not necessarily something you'd expect with neuroendocrine.
So Dr. Tan, would you, if they saw you in the office now, would you consider biopsying? Yes or no?
So very often I would say no. It's something that we can consider, but I would clinically in this case not do it. I agree with Dr. Punnen that the PSA was rising and it connotes more of aggressive disease.
Dr. Taha, really quickly, yes or no? Just out of impulse?
No, I wouldn't. If there was metastatic disease to visceral, like liver, then absolutely. But outside of that, no, the PSA was rising anyway.
Okay, great. All right, so we're going to move on with the presentation. I think it's Dr. Tan or Dr. Kasraeian, whoever is who's presenting. Go ahead.
So what we did is we referred to to medical oncology and radiation oncology a little bit later on, but we brought them into the conversation early. And one thing I urged with people, the minute I saw that PSA, my first conversations were to my medical oncology and radiation oncology, just to make them aware of this gentleman, so that they knew the story and knew that I would be sending referrals into place so that we can build essentially that multidisciplinary team and essentially create that tumor board concept in the community, being that we don't have a place that we all sit together like an academic setting does. And then we talk throughout his initial therapy in the weeks that we were deciding what to do with the patient and separately.
I think I agree with Dr. Kasraeian that early on, every patient with new onset or early metastasis or high-risk prostate cancer should have a full discussion between urology, radiation oncology, and medical oncology. And as you are aware of today, which is not diverting, but just trying to inform our colleagues here that there are some new adjuvant treatments that we actually are testing, clinical trials that are important also for high-risk prostate cancer, like this patient retrospectively. Moving forward, we would like to engage you in a conversation today. If this patient was presented to you, our colleagues in the on the Zoom, what would you do in this patient? Would you do surgical castration, medical castration, single agent bicalutamide, which often is used actually very frequently, or combination treatment with leuprolide and enzalutamide or leuprolide docetaxel? And maybe you can engage us with your conversation, your thoughts, and what you would do on this patient if this patient was presented to you. Anybody can chime in, and we would like you to be involved. And last but not least, we would like to hear Dr. Taha's comments after your comments.
So Dr. Tan, I'm not sure if the attendees can actually speak up other than the chat function. I'll have
okay. I cannot see that.
Look into that because I've been trying to get some of them to talk, but I think once they're in that one, they can't clearly openly do it. But we'll look into that while you guys are having the conversation on this. But here's a question while we're trying to figure that out: is between urologists and so go ahead, yeah, Danny. Thank you for the chat, guys, go ahead. We have like 47 participants put on there. I'm gonna, while they're putting their response to this question, my question to you is this first step that you mentioned, Dr. Tan. Is it better that you would say that the urologist initiate this, or if we are going to refer to medical oncology, would you say there's a difference in someone that's in the community versus academic institution in terms of where we refer these patients to?
Our hope and our vision would be that there should be no difference. I think the key here is teamwork and collaboration. Everybody can do this, whether you're in the community or you are in the academic setting. Be open-minded. If you are a type of urologist who really don't want to take care of patients with metastatic disease, just refer them to your medical oncology colleagues. But if you want to collaborate, please do collaborate with medical oncologists, because at this stage and point, there are multiple new studies or new data that would support many things that can be done for your patient, and that becomes our patient together.
No, thank you. That's a great answer. So we do have some responses. It seems like the fourth option is the more popular option, and then there's an option here that's not listed. There's refer to medical oncology to figure it out. That's the option that I would probably pick as a community urologist.
Well, as a medical oncologist on the panel, I think the combo option, which the majority of the chat answers is spot on, and we'll go into some more information within this presentation as to why.
And really quickly, I was just told if the attendees raise their hand on the Zoom, so there's a little thing that says raise hand, we will turn on your mics, and then we'll be able to hear you. Hopefully you're raising your hand not because you want to go to the bathroom, but because you want to have something to say. So we don't want to turn on your mics when that's happening. But if you'd like to engage physically in the conversation, please go ahead and raise your hand. With that being said, I'm going to kind of let you guys.
Jamin, I'll make one point to that. This doesn't necessarily, and really, in my opinion, shouldn't be an either or thing. This should be an us thing. And I think the collaborative aspect of thing between urologists, whether it's someone who's really engaged in prostate cancer and this is something they're really, really passionate about and like taking care of, or someone who is not, I think the referral to medical oncology in the setting where it's appropriate and knowing when it's appropriate and early in the disease course where that becomes appropriate is important, but staying engaged in the patient's care and seeing the patient at incremental timeframes that doesn't necessarily have to be every time that they see the medical oncology, but in staggered approaches or a variety of things that's comfortable for the patient, that's appropriate for the management of the patient, making sure that they're seen by the medical oncologist, but also for them to know that their urologist is still part of the management of their prostate cancer, should they have questions that are very prostate cancer specific for the urologist. And it helps breed that collaboration, not just for that patient, but for future patients in the future.
And that's very true. I agree with Dr. Kasraeian that this is a team approach, because along the way, patients with metastatic disease can develop urinary obstruction, can need some stenting, can need multiple procedures, and can have hematuria. So a team approach, and the urologist and the oncologist seeing the patient together would be the best approach for this patient, and in addition, the radiation oncology.
And it's possible in the community setting. I mean, I really talk to my medical oncologist and radiation oncologist and my radiologist who reads my MRI scans and body imaging, probably more than I speak with anyone else in the clinical setting on a day-to-day basis.
No, that's fine, Ali. So really quickly, so we had Julie Newberry raise their hand. Please chime in, turn your mic off, and you're welcome to engage in the conversation.
Hey, it's Wayne Brisbane from the University of Florida. I might be linked to Julie Newberry, but I was just wondering, so I'm working with a medical oncologist to do next generation sequencing in metastatic disease, and it always kind of comes up, should we be targeting these lymph nodes or should we target the prostate? And I don't have a good answer, so I was wondering what the panelists think. I think obviously the clones that are in the lymph nodes are probably the ones that you want to target, but they can also be a lot higher risk as far as a biopsy, where we can get decent amount of tissues out of the prostate. And with imaging guidance, can probably get a pretty good idea of what the main driver of disease are. But I was just wondering what you guys think about that.
I think we all know that there's tumor heterogeny, and it's a tough question what we target, the prostate or the lymph node or the metastatic disease. But since we're taking care of a patient who I always think is like us, we don't want multiple biopsy being done on a patient. So we would target the metastatic area like the lymph nodes, or basically the liver or the lung, which would have a higher yield potentially of the driver mutations that are involved in the disease.
That's a great question. So for the sake of time, let's at least finish this case, so then we can continue the engaging conversation. So Dr. Kasraeian or Dr. Tan, go ahead and finish this case off for us. Not the patient.
We will present the full data and the names of the study later on. But in this patient, the most appropriate option for this patient would be ADT plus surgical castration plus docetaxel, enzalutamide, apalutamide, abiraterone, and prednisone. So let me ask Dr. Taha, in this setting, how do you choose between all these options? And they are all appropriate treatments for patients with hormone-sensitive disease. And there's always a challenge and a question to medical oncologists, urologists, or radiation oncologists. Is this a mystery? How could you clear up that mystery, Dr. Taha?
Great question, Dr. Tan. I really look at the patient's performance status and their comorbidities. For example, we all know with abiraterone, you needed to utilize prednisone. And so someone who's a diabetic or pre-diabetic or has any reason not to utilize steroids, I would kind of steer them away from that choice. Oftentimes, their insurance carrier helps make that decision. Unfortunately, that's the way it is. We know they need AR-targeted therapy, and we have multiple options. And quite often the options are depicted by their insurance carrier, but we look at their comorbidities, look at their performance status, look at whether they have a history to seizures or asthenia or fatigue, and make our decision, or at least I do, make our decision in regards to the side effects that may occur based on the patient's medical history at that time.
Thank you.
Sure.
So really quickly, someone sent me a question here in private. They said, everyone says urology and medicine should follow them together, but sometimes it seems like redundant and waste of time for the patient to see all of us. What would be an ideal follow-up plan for all, where we're not ordering things and then doing things over and over again?
I could take a shot at that. I mean, so I think in terms of an ideal follow-up plan is going to obviously depend a little bit on the patient. But I think there's a couple of things that I definitely heard and totally agree with, is that these type of patients do often require and deserve a multidisciplinary approach. As Dr. Tan said, even if you have a urologist that may not be that interested in advanced prostate cancer, these patients are still going to require a lot of local things to deal with, side effects, stenting, catheter, retention issues, bleeding, hematuria, stuff that will require a urologist to be involved. There's a huge role for radiation. So I think Dr. Kasraeian mentioned that, he talks a lot with the radiation oncologists and medical oncologists in his group. And so I think what you have to find out is, who are your partners in this? Who are the people that in radiation oncology, medical oncology, urology that you are going to form a team with to do this in? And then you develop your approach. I mean, this is a very dynamic field. It's constantly changing and people are going to have to be update and move with it. So you may say, this is our team's approach to first line therapy in these patients. And this is what we do if they fail and they go to second line. This is when we sequence them. And you have those kind of discussions, up front and know what your team is, what your approach is going to be. That way you're getting the same message, from each provider. That patient is hearing a consistent message, and you develop a follow-up schedule that's patient-centered, not provider-centered, right? And as the data moves, you as a group move with it. So that's the approach that we tend to use. I think it works the best. Patients seem to like it.
And another thing that it actually helps with in terms of that aspect is, Dr. Taha mentioned the financial aspect. For a lot of patients, what test, what medication that we use, even sometimes, lately the hormone blockade over the past few years has been difficult to get financially in some insurances and some coverages. So working in concert with our medical oncology colleagues and some radiation oncologists colleagues together with our teams working together, we find which team actually has the better bandwidth or has the relationships or the ability to get some of these treatments pushed through or imaging modalities done quicker. For example, the Oxyman scan, our medical oncology team has their own scanner that does Oxyman scan. If someone really can't get it, they're okay doing it and just kind of not worrying about the cost and the finances if it's the right thing for the patient to do. If I didn't have access to that, or if we didn't have the volume of collaboration, that would not necessarily be possible. So it helps our patients and it gets our patients the things that they need sooner, and we don't have to worry about who gives the medicine and who does what. We just know whoever can get it to them sooner that with the most ease can do that. And then we kind of figure out for each patient, like Dr. Punnen was mentioning, how to stagger those follow-ups. Some people want to be seen by everyone more often. It makes them more reassured. It's okay from there. We have people that come from out of town. Everyone sees them on the same day. So we do a lot of things to make it easy for patients, and we don't all get different lab tests or imaging. We do them together because we know we're all going to be looking at the same test, usually at the same time.
And the key there is communication. I think you talk to each other so you don't have a lot of redundancy. Another thing that I want to mention is there's so many multiple options for this patient. One of our partners is industry, actually industry, navigators, social worker, our APPs, are other part of the team. We should give them value because these are people who can help with access to these medications. Industry and pharma have patients assistance program. They look at their income, and if you're at a certain level, they might be able to provide free drugs to patients whom their insurance would deny access to medications.
Awesome. So what I'm going to do next is this is great conversation. We have tons of other questions, but I'm going to just give Dr. Taha his few minutes on the agenda here to kind of discuss how kind of trying to put everything we're saying together and visually kind of presenting it to us based on guidelines that we may see on a day-to-day basis in our offices. Dr. Taha?
Sure. We all know how important the NCCN guidelines are in regards to getting things approved, but these have been approved not because there was a panel that came about together and said, well, these are the better drugs, or these are the reasons why they should be approved. Let's just put them on a slide and say this is what clinicians should utilize. Actually, they're proven by clinical trials, and I'll go into detail some of those clinical trials that show exactly that, hey, combination therapy is the way to go for our patients. These are some of the trials, and I'm not going to go into details of specifics, but these are combining ADT therapy plus is really the way to go in regards to how to treat our patients. And we want to do it as a team approach. As a medical oncologist, Dr. Kasraeian, he was 100% correct. The first thing I do when I receive a consult from a urologist is give them a phone call and just see how they'd like to handle in regards to what they're already receiving it. Many times the urologist is given the ADT therapy, and I'll just piggyback off of whatever they are not giving. And we work together as a team. For me, it's very important that next generation, as an oncologist, make sure I support my urology team from a multidisciplinary standpoint. Yes, sir.
So Dr. Ha, some of your audio went on and off, but just two quick highlights. I think you said, what was the conclusion from this study? And I think you said you love your urologist, correct? Okay, just wanted
yeah.
got the second part up.
Yeah, that's definitely the main point.
I don't know if you get cut off, maybe Dr. Tan can summarize it.
I just wanted to let
So the trials here.
you know that combination therapy.
So thank you. Sorry for the technical failure there, but the different clinical trials here, chemotherapy, oral agents, abiraterone, apalutamide, and enzalutamide, based on randomized phase 3 clinical trials, have showed indeed that we can improve overall survival in patients with a doublet.
So one thing here, Dr. Ha, which if you don't mind emphasizing again, is that part right here that's bold on the bottom, which I kind of sped through when we were going through the slides. But I think this is so important for us to kind of emphasize is guidelines, and then there's reality.
Yeah. Single agent ADT therapy is no longer appropriate for your metastatic patients that are castrate sensitive. And combination therapy, the earlier you introduce it, the better the response rates and the better the survival. And those studies we highlighted earlier prove it. And I apologize about the technical difficulties with my internet and audio.
No, it's okay. We got most of it. So for the medical oncology colleagues, when we send them to you, we want them to get the best outcomes. I think someone mentioned optimize them medically, et cetera. What can we as urologists do before we send them to you to kind of make them better candidates for some of these things? Obviously, weight loss, exercise, optimize their mental health. But is there anything else that you may be seeing that, Punnen and Kasraeian may be doing it right, but like a Brahmbatt from the community may not be doing it right, that we can kind of help?
I think the key here is the collaboration. Refer them early when you have a high-risk patient, high risk for metastasis, or a newly diagnosed metastatic patient. Start that conversation, find your favorite team so that you can collaborate with them early.
So I think as moderator, I think there was a slide that Dr. Punnen was supposed to go over.
The NCCN.
Yes. So I apologize as moderator. I kind of sped through some of these things, but to Dr. Punnen, we will definitely give you the spotlight, my friend.
No, but I think we touched on it. I mean, the point of this slide is just showing to the left is the AUA guidelines, which is, the body that the urologists kind of follow. And to the right, there is the NCCN guidelines. And you can see that it's concordant. And I think the bottom take home from this is, if you look at what for urology, for example, in the AUA guidelines to the left, it'll tell you what clinicians should do. Under clinicians should not do is you can see just offering, a first generation anti-androgen or just, ADT in general on its own. So I think, we said this before. I think in the past, when we didn't have other options, we just put these guys on ADT, but the field has changed drastically. We've seen lots of evidence that patients do a lot better and survive much longer if they're on an additional medication, and there's lots to pick from. So I think, that point's been brought home.
So that being said, we have about 10 more minutes here in our conversation. We've talked about a lot of, we had a lot of different discussions, but let's say you have other questions, please email info@flasco.org. Whether you want to hit us up individually, you can hit us up on the chat, or you can ask for our information. But this really has been a collaborative effort with FLASCO where Dr. Taha is the current president, and the Florida Urological Society, which represents us as urologists in the state of Florida. And it's been pretty cool seeing over the past 18 months how it's kind of coming together, whether it's with educational material for patients, or collaborative meetings between our specialties, or this first didactic conversation here online. So that being said, final thoughts, guys. If anyone has any questions, please post them in the chat, or if anyone raises their hand, we can get you involved here. But for the panelists, if there's a takeaway here, please, 30-second takeaway, that'd be great.
Our greatest takeaway would be to learn from you. What are the challenges of doing second generation ADT in your practice? Please let us know. Put it in the chat, because this is a conversation as we started out. So we want to hear from you.
So Dr. Chan, there's a question. How do you monitor cardiovascular health, especially for our patients with APC and significant cardiovascular chronic conditions?
So I think we describe to them about cardiovascular health, but at the same time, we have a team of what we call cardio-oncologists, and they help us monitor those patients to look at their cardiovascular risk, control their hypertension, control their diabetes, control their other comorbidities, and we co-manage them. They see them every 3 to 4 months if necessary, but at longer intervals if they're stable.
So now we're adding another specialty, the cardiologist, to this whole algorithm here. Dr. Punnen, Dr. Kasraeian, you're in academic settings or pseudo-academic settings. Is this harder or easier in the settings that you're at?
I don't know, to be honest, whether it's harder or easier. But I agree with what I've heard before in terms of, the main take home to me here is just having a team approach, multidisciplinary care and having frequent engagement with those colleagues that are practicing in this area to see how you as a group want to deliver care. So you have a consensus message that you're giving to the patient. So that would be my kind of take home.
From my perspective, I echo that. I'm in a 2-man urology group with my dad, essentially, and so the relationships that I've found important for this is finding people that are as passionate about this disease as I am, and that we work together to make sure we give our patients the best treatment, and that they have the same philosophies for communications that I do. And again, I'm out of my fellowship since 2008, and over that time, that has not been difficult to do because the technologies to allow us to communicate very, very easily, and HIPAA compliant communication is fairly easy. So you can create the same academic level multidisciplinary conversations without having to be in the room together running multidisciplinary cases, because that logistically in a community setting would be very, very challenging to bring 3 specialists out of their clinics and put them in a room to go over 10 cases. And so that becomes impossible, unfortunately. I'd love to do it. It'd be amazing. But we essentially create that every time we talk. When we do actually sit and talk about one patient, inevitably we have 3 or 4 other patients that we're talking about as well. So I urge everyone kind of listening, those same collaborations that you have in those conversations that you have in the academic setting, in the community setting, those can transcend where you go. And in the academic setting, teach your residents how important that is, because not all of them are going to stay in academics, and you can go and bring an academic mindset to the community. And that's very fulfilling because you get to do something like this and be on a call with some really, really cool colleagues. And for me, again, Jamin alluded to it, the opportunity to be part of this team with FLASCO and these panelists to come up with some of the ideas and the thought processes to potentially go out in our state and find the issues that we individually face in bringing these next generation medications and imaging modalities and things that really are going to advance prostate cancer and how we manage this disease in such a impressive way. Even for none of us on this call are really that old. to watch this disease mature in the advanced state in this generation is pretty impressive. So if we can all work together and find out what the shortcomings are to getting our patients these therapies, I think we can use that information and collaboratively and all together go to industry, we can go to government, we can go to payment models, whether it's Medicare or insurances, and tell them, we're not doing a good job nationally, we're not doing a good job in our state. Here's all the reasons that we can do. We're all committed together, and we're committed for our patients. And I think that's important for us to do, because as you see, in the nation, we're not doing well with this. And in the state, it's a great opportunity for Florida
Ali, really
to show us
quickly,
how to do this nationally.
Ali, we have a question from the
Sure.
audience. So how would you treat a 50-year-old otherwise healthy patient with seemingly localized Gleason 8 prostate cancer, status was prostatectomy with one lymph node positive, and it's in the chat, guys, so if I'm reading it wrong, serendipitously on post-op path, PSA 0 post-op, pre and post-op imaging were negative for lymph nodes or distant mets.
This obviously is a high-risk patient, and talking about molecular markers, I would do genomic and somatic mutation, looking for those. I would reach out to my radiation colleagues. It's not wrong to treat with single agent hormone treatment, but I would put this patient on a clinical trial if possible.
So really quickly, Megan, if you could turn your screen on, would love to hear, we keep mentioning industries. We mentioned us as specialists, et cetera. What are some of the things that industry are doing to kind of help with this collaboration? Megan or one of your colleagues?
Thanks, Dr. Brahmbatt. I'm not sure my camera works, but that's just fine. Julie, don't turn it on, please. But yeah, Pfizer is really committed to working with specialists to make sure that patients are front and center, and ultimately that the patients are getting access to therapies that are meaningful to them and their families and their livelihood, and supporting providers like yourself. So we are just really privileged to work alongside you today, support of this education, to continue to improve the dialogue and the conversation. You all were leaders, and there's many leaders that are on the line today, that last year did a survey, right? And one of the areas that came out of the survey that was done was a need for improved education. And that was really the purpose of today. So thank you for the opportunity to come alongside you. I know there's a few more exciting things coming, but thank you again.
No, thank you, Megan. And thank you to all our partners in the industry for everything that you do for our patients. And just for the record, none of us were, our arms may have been twisted a little bit by Dr. Dan and the rest, but we all do this at the kindness of our heart, and we have no disclaimers when it comes to the conversation we're having on this forum today. So one question that came up is, Dr. Tan, what assays do you use to perform germline and somatic mutations?
There are many commercial platforms. I would not mention them because that would be biased, but there are many platforms that are available today, depending on your institution. You can refer them if you don't like to do it yourself. You can refer them to the medical oncologist, and the medical oncologists have their favorite assays that they can do on their patients. I can ask Dr. Taha what he would do in his institution. That might be a fair question.
You hit the nail on the head, Dr. Tan. Every oncologist or clinician has their own favorite genomic testing. One thing I do right up front is I ordered liquid biopsy and tissue biopsy right up front. Like Dr. Tan stated, I'm not going to mention specifics because it really is personal choice, and I want to keep this educational rather than biased. But I do, from the first consult that I see the patient, I will order genomic testing when appropriate from a liquid standpoint and tissue standpoint, especially because of tissue heterogeneity, like Dr. Tan mentioned earlier.
That's awesome, guys. So that being said, as promised, we will keep the conversation to an hour. Everyone has many other things that they have to do, and we appreciate you taking the last hour to spend with us here. I want to give a big round of applause to Dr. Tan for kind of spearheading a lot of this, and also a round of applause, at least a virtual, to our speakers and experts, Dr. Punnen, Dr. Kasraeian, Dr. Taha, for giving us all your insights. And listen, the conversation just begins today. We're going to continue this conversation, whether you continue it in your separate facilities or you email us at info@flasco.org to continue the conversation in forums like this. Every question that's asked is going to get us one step closer to having one less question in the mind of our patients. And that question that we want to get out of their mind is, am I getting the best care? And the best care comes, as we have heard so many times, with collaboration. So thank you. And hope you guys have a great night. Be well. And we'll see you on the next conversation.